Ahead and get started. Again, my name is Nicole O'Kane. I'm the clinical director at Acumentra Health, and we're here today, part 2 of our 3-part series, learning a little bit more about chronic pain management and some new approaches to managing that pain. Okay, so again, I just do a little bit of background here at the beginning. I believe that most of you were on the first call, but if you weren't on the first call, that's fine. We'll be doing some quick review throughout the call, going over some of the things that we talked about back in September. But mostly just to frame that the purpose of this series is really for you to prompt some further improvement in your nursing home settings. We really want to look at the management of chronic pain conditions for your residents. We would try and improve some of the effectiveness and especially the management, and so we can improve the quality of life of our residents. I want to introduce the Acumentra Health team. Today with me I have Tyler Havlin, who you know well, our project coordinator. We also want to introduce a new lead project coordinator who's just started this week, Leah Brandeis, and I want to welcome Leah. And so again, this is our Acumentra Health team, and you will be able to follow up with us if you have any questions at the end of the webinar. It sounds like we have some great participation from across the West. As with our first webinar, we have more than 100 participants, so that's great that there's a lot of interest in this topic. We are in Oregon, of course. We are part of a Health Insight network. That network of Health Insight is Nevada, New Mexico, Oregon, and Utah. And we also join our friends to the north and to the east in Washington and Idaho. Qualis Health is another quality improvement organization, and they're joining us, and some of their homes are joining us as well. So really have some great participation across the West. So hope to get some good work done during this webinar and get you thinking a little bit more about what you can be doing in your setting to try and improve upon chronic pain management. I need to do a little check-in because I cannot see your smiling faces. So wondering who is participating on the call today. If you want to type into the chat, Tyler's going to be monitoring that for me. And my assumption is the majority of us would be nurses. I'd also heard that there were a few pharmacists on the last call, so I want to give a call out to my colleagues. I am also a pharmacist. I understand we have some nursing administrators probably in the room as well. And then, as I mentioned, some people from a quality improvement organization. So just a little curiosity about who is out there. I also heard that we have a couple of public patient advisory people that come and listen and help us to guide some of our messaging. So I welcome those folks as well. As we do this talk today, I am going to step it up a little bit more with the technical terms. My primary audience today is really the nurses and pharmacists, and a little bit more clinical than what we did last time. I apologize for some of the administrators, or if there's long chemical generic drug names that we're passing around that might go over your head, but that's fine. I think we want to try and really focus for the nurses on what they need during this call. Just a quick reminder about how we run these webinars, because again, I cannot see you. We do try and use the chat as much as possible. I will be presenting, some chat questions throughout, just as I did last time, to try and continue to engage you. I appreciate your comments back. During the call, if you do have questions, Tyler will be monitoring the chat session, so feel free to jump in and type in a question. If something's not completely clear, again, because I can't see you, I don't always know if the message is hitting home or if there's some confusion. So feel free to type into the chat throughout, and then we'll have some time at the end for questions as well. And the other thing is that some of this is repeat information for you, but some of it is new, and really the framing under which we present some of it is new. So I want you to be open-minded to some different ideas and some different concepts as we introduce them. And then realizing that I cannot help you, I can help you help yourselves. And that's how I try and run my seminars. By myself, I cannot teach you pharmacology, nor would I want to. But what I can do is provide you with tools and provide you reminders of what you have all learned before in your clinical training, and think more importantly about ways during a very busy day while you're taking care of residents and while you're assessing their pain, what are things that you can do to bring in a new way of thinking about pain to the entire organization. So it's not just about nurses and pharmacists, but really all of the staff, whether it's people that are working in food service, whether there's volunteers. It really is changing a culture around pain and how we think about pain. So that's how quality improvement happens, and I'm glad to be walking this journey with you. Again, I mentioned Health Insight is the primary quality innovation network that we work under: 4 states, Nevada, New Mexico, Oregon, Utah. And for the folks in Oregon that know us well, they know us by our name is Acumentra Health. But if you see Health Insight on a lot of our training material, that's because we affiliate with them through this Quality Innovation Network. A little bit of background about why we're talking about pain and why we chose this series of webinars to learn more about pain together. In Oregon, our nursing home quality care collaborative chose this topic. They looked at some of their composite measure scores. They were looking at some areas where they thought, well, we're doing pretty well in some of these areas as they looked at their metrics. But there were some areas where they thought, gee, we sure could use a little bit of extra help in this area around pain. So we focused on pain management, and we chose a goal to improve the percentage of residents who self-report moderate to severe pain. I think it's important to realize that it's one goal as part of, our MDS scoring includes many different ways in which we can measure pain. This was the goal that we focused on, recognizing that some people are going to have some pain, but we want to do what we can to avoid moderate to severe pain in that assessment. So another quick check-in with the audience. Is your facility currently working on a quality improvement initiative that includes pain management? We know that our Oregon nursing homes are doing that work, and I wondered if in other states this is a big focus for you. It looks like it is, and I think across the country we know there's a big struggle around how to treat pain, how to make it a multidisciplinary approach, and it is a real challenge across the population, whether we're working with elders or with younger adults. So I'm glad to hear that so many people are focusing on this complex but important topic. So again, 3 parts. It's such an important topic, and it's so many aspects of it that we broke it into 3 webinars, and I appreciate your continuing to participate. In part 1, we did an overview and really talked a lot about pain, concepts of pain. Today, we're really going to focus on pain interventions, treatments, and other...
The conference is now being recorded.
Treatments and other interventions that really can dive into what can we do about the pain. But really the most important part of this, and really where I know that nurses start when they're thinking about a resident and what their needs are, is you really start with assessment. But because assessment is such a big part of the solution, we believe, we save the best for last. So we're really going to focus on interventions today, keeping in mind that come January, we're going to dive in a little bit deeper on MDS, scoring, using different pain tools, assessment, and how we might kick off this webinar to get you thinking about within your facilities, what are other things that you need to try and improve this topic. So our objectives, we have 4 objectives. You've seen them before. They were on the introduction. I won't read them through, but really I want to focus on some major areas. We really want to talk about the model of chronic illness and this concept that I introduced last time. I know nurses are very familiar with it, but this idea that there's sort of a biological, psychological, and social component to our health and to different illnesses. So we want to focus on some interventions that use that model. We want to talk about some non-opioid medications that are used to treat different pain conditions. I want to do a little bit, I promise we won't do too much math, but a little bit of discussion about calculating opioid doses, because I think that's important when we're changing doses and being aware of being safe with medication doses. And then especially number 4, looking at suboptimal treatments. That's really a theme that we'll go throughout this webinar as we talk about, what maybe we haven't been doing in a sort of suboptimal way, and what can we add in that makes pain treatment more optimal. So, and of course, as a pharmacist, I always want to focus on safer alternatives whenever possible. So I introduced this last time, and I think it's important to state it again. Being pain-free is an unrealistic goal. Whether you're in your 30s, 40s, 50s, or as you become an older adult with chronic illnesses, perhaps, if you've had either a motor vehicle accident or something that's happened in the past, all of the people that I just listed, no one is pain-free. And this is an unrealistic goal. Unfortunately, due to probably many components, including good intentions by healthcare professionals and a lot of advertisement by the pharmaceutical industry, among many other things, this has sort of become this idea that, well, I can take a medicine and I can be pain-free, and it's just not true. There's no evidence to support that, and I think if you think about it for a minute, you know that there is no pain-free place that we can live for 24 hours throughout the day. What is a better goal? Let's think of a more realistic goal. So we know that aging contributes to having more painful conditions. We also know that through good assessment and management, we can have a good quality of life. Now, there is good evidence for that. No matter how difficult your painful condition is, people do manage to have a good quality of life. And really, that is our goal. As I mentioned earlier, getting away from that severe pain and having a place where we can live. Living with the pain is sometimes what the psychologists use, but then also being able to live. Some general principles of chronic pain, and this is really the sort of an overarching approach. When we talk about treating chronic illness, whether it's pain, whether it's diabetes, we always want to use an interdisciplinary approach. There's different professionals that can be brought to the table as experts in quick team huddles in different ways as we're focusing on people that have chronic illnesses that are associated with pain. So we always want to include more than just nursing, more than just pharmacy. It's really a broad approach to chronic pain. Always, 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 there has to be non-pharmaceutical components to any treatment. This is true whether we're talking about cholesterol or diabetes or pain. We never just use medications to treat pain. I always want to make sure the goals are measurable and clear, and not only clear in our care plan, but clear to the family, clear to the resident, clear to everyone who's part of the team, so that those goals drive that plan. Because for what one person may be a goal of, I really just want to be able to come to lunch every day, and even though I have a little bit of pain, that's okay. I want to go to lunch every day. That's my goal. For another person, maybe they're less interested in other activities. Maybe their goal is they want to sleep at night, and that's the most important thing for them. So obviously those interventions are going to look different for those two populations, always based on the resident's goal. And although that seems obvious, I think it's always important to state. We want to follow principles of pain assessment, and we'll be, again, following quite a bit of detail on our next webinar in January. We want to evaluate the effectiveness of all therapies. So not only the medications, where at the beginning I said we don't know how effective some of these medicines are, and they're not always 100% effective. We also want to be aware of those non-pharmaceutical interventions. If I say, you don't need to take that medication, I can use massage. Well, what is the effectiveness of massage in that condition? For some conditions, I think you'll find that some of the non-pharmaceutical interventions have good evidence, but it depends on the condition and it depends on the individual. So always driving our treatment plan based on effectiveness, not only based on what we know is effective from evidence-based reviews, but we know what is effective based on, we know this resident. We know what's worked in the past for her or him. preventing and managing medication-related adverse effects is always going to be part of a pain management plan because by definition, any medications can have adverse effects. So anytime you're taking medicines, even if they're medicines that we think of as having a very low incidence of side effects, we still want to anticipate as much as possible that they can be happening. So we'll talk a little bit more about that in this section, especially as it relates to opioids, but with all the medications. And then understanding outcomes and that piece of communication, not only for the caregivers, residents, family, but everyone really that surrounds the resident, that everyone's on board with that plan. So today, and as I just introduced those principles, I've been using a great website that I think you'll find very useful, and I'm going to be referring to it again and again today. As I mentioned at the beginning, I cannot teach you everything that you need to know about this topic. I can introduce you to some of the topics, and more importantly, I can guide you to this incredible website that's been put together by academics and people that work in long-term care. So sounds like from the chat conversations that Tyler's summing up, some people have visited, but certainly there's a whole bunch of you in the audience that have not visited it, and that's fine. What I just needed to know that so that I want to walk through it and really, before the end of this webinar, I think you're going to be really excited to go and visit this. And I believe that as we begin to focus on some interventions and some things that will be happening within your quality improvement project, that you're going to be going back to this website again and again because there's lots of great tools there. So this is the Geriatric Pain website. It is a website that has a fairly straightforward setup. So sometimes you get to the FDA websites or the CDC websites and you kind of lose yourself. This is set up pretty straightforward. So on the left-hand side, there's some main categories: pain assessment, pain management, education, quality improvement, resources, frequently asked questions, and the MDS3. And as you click on each of those sections, you go into some details, but the majority of what you're going into are 1 to 2 page fast facts, they call them. So if you pick a topic, there's information in there. It can be printed out. It can be used in training for your staff. If you want to, at a staff meeting, want to do a little Jeopardy game of who knows what about some pain management, there's a Jeopardy game in there. So there's some fun things. There's also videotapes, MDS training. There's information about other federal requirements. So from a nursing administrator approach, there's lots and lots of information. So I drew from this almost exclusively, this and the guidelines that are out there on this topic. And so I'll be referring back to this again and again. In this first section under pain management, there's some core principles. We just went through those core principles. There's some information about terminology. A lot of an area around interventions, which I will get to in a little bit, but really, again, I want you to go back and see if you can't use this website. The majority of the resources have been developed specifically for older adults and for use by nurses and other staff in nursing homes. So it is specific to your setting. There are a few sections that are related to just adults. So there's a dosing section. The medication doses are just based on adults, but anything that is not specific to geriatric medicine is clearly marked. The other thing is the background for this website. It's been, it was reviewed for Oregon Health Science University is our local university, is the medical school and a great facility in Oregon. They were part of the review, as well as the University of Iowa. Sigma Theta Tau is the nursing association. So it's well versed in the expertise. It's updated frequently, like every month they have additional updates. They take comments. It's all free of charge, and it's for you. It's been developed for you. So it's not an advertisement. It's not from the pharmaceutical industry. It's been really well vetted from an academic standpoint, as well as nurses that are working in your setting. So I'm really excited to have found this site. Just a little bit of further drill down on these interventions. There's some information about side effect management, looks at some serial trial interventions. We'll talk about this more as we go, but there's a lot of interventions, one-page summaries around non-drug pain management, and I would encourage you to look into that section and see if there's information either that can be helpful for you and or as family members have questions about pain and what we do for our residents that have pain. I think these were incredibly useful as just good talking points. The area that also will be useful from a nursing and administrator perspective is the educational resources. There is modules that include CME. There is specific areas of interest, ruling out abdominal pain, specific information about headache pain, neuralgia pain. So again, it tries to drill down into these small 1 and 2 page quick summaries of a topic, but they really, the newest topic that they added last month was pain on urination and ruling out whether it's a UTI or whether there's something else happening, if there's medications causing it. When under what indications would you make an additional action and how that would work. So they're continually updating, continually bringing what I would say is practical information sort of on the ground. This is not your nursing chapter 13 that you probably can't use within a busy work setting, but something like this certainly is something that you would be able to use and use as a good reference. So as I said, most of the information that I'm presenting comes from clinical practice guidelines. You're probably familiar that the American Geriatric Society came out with some excellent guidelines that have been the sort of the cornerstone of this work. They updated them in 2009. They haven't been updated since, and it's my understanding that they're in the process of updating them. In 2002, they did a full review, including the non-pharmaceutical, pharmaceutical interventions. And when they updated in 2009, they only updated the medication section. The other parts of it, all of the studies and the evidence were still the same. So that's what I've used. There's other guidelines that are very similar. I found the American Society of Pain Management for Nursing helpful because they focused further on how to work with patients that are maybe don't have as verbal of an ability to communicate, but how you can use other tools and other skills. So that was helpful as well. Most of you are probably aware of or have seen somewhere this WHO pain ladder. It came about in the 1986. It's simple, it's incomplete because it really only speaks of medicine. But the concept is helpful. So when we have pain, the step 1, I would say, is a non-pharmaceutical. So the step 0, maybe their very first step is the baseline, really should include non-medication related interventions. But then within that step 2, since they were really just focusing on medicines, and this was originally developed for cancer pain, they stepped right into the medicines, looking at not an opioid, but a non-opioid medicine and then an adjuvant medicine. And then continuing to assess, and if the pain persists, you keep that first layer, but then go up to the next, probably adding a mild low-dose opioid for moderate pain, and then continuing to add others as we go up. The idea being you always want to keep the baseline, always be reassessing, always be aware that you can go up on the dose of a medication if you need be. The downside of this work that was done in the 80s and 90s for cancer pain was that it got introduced and applied to people that don't have cancer, that aren't in a palliative care setting. So a person after a knee surgery who's 40 years old, I think you heard the president speak last week, over the last couple of weeks, to talk about the prescription drug epidemic that we're having in this country right now. Some folks believe that this idea of upping doses for cancer patients, which is legitimate when they have chronic, they have pain, is not necessarily legitimate for a younger population that's going to live another 30 years. We don't have evidence for long-term use of opioids, and we do have evidence that we are getting a lot of side effects, a lot of deaths related to the use of these medicines. So I bring this up again. I spent quite a bit of time on it during the first webinar, but I think it's important to realize this is a balance. We want to address pain and get the amount of pain relief that we can from medicines. We also want to make sure we have non-medicines on board to be doing that work as well. And then the complexity of who is that patient and what are their goals. A patient that is in a palliative care setting with a care plan that's well defined, we're less concerned about upping doses of opioids as long as we can manage the side effects, keeping that quality of life for that person. Versus another person who is not in a palliative care setting, their care plan they want to be up and around moving. They don't want to have a high risk of falls. That care plan would look very different. A preferred way of thinking, rather than the WHO pain ladder, I think is this serial trial intervention. And this comes from the website that I referred to earlier, where we're really talking about a serial trial. It's not a ladder as much as it's a try, check, reassess, try, check, reassess. So you're doing a physical assessment, you're doing a screening for depression. A lot of people that appear to have pain from a physical ailment, it may be that they're also depressed. So a huge component of assessment includes screening people for depression and other situations, other conditions that can be going on. Everything from other illnesses, medical illnesses that can be happening, as well as behavioral health situations that can be happening. We always trial a non-pharmacological intervention. We're constantly trialing because people's pain can change. We use the term chronic pain, but actually most professionals prefer the word persistent because it can come and go. It's there with you, but some days are better than others. Some trials work better than others. We certainly know as the weather changes, there can be some increased inflammation. And then, once the barometric pressure settles down, people do a little bit better. So always trialing, retrialing, checking that intervention. And then if there isn't an ability to manage that pain, a consultation with a specialist. So I want to make sure you're still awake out there. So I got a polling question for you. What % of older persons living in long-term care facilities suffer from pain problems? Where do you think this spectrum occurs? Between 30%, 50%, 80%, 100%?
80 and 100% is what everyone says.
Yeah, everyone knows it's high, definitely. The trick question is it really isn't 100%, especially once we assess people's other discomfort. I mean, I spoke of depression, or a person originally feels like this person may have a pain and there may be some persistent pain, but once an assessment is done, once perhaps in some cases, there can be some therapy, there can be some medications that are added for that depression, and then it turns out the pain does go away. And then we know later, well, it wasn't actually related to a painful condition as much as they felt emotional pain, which we do as part of depression. So the catch here is that it's difficult to measure what causes that pain, especially if we include physical, emotional, and spiritual pain. So 80% is the answer. So here's the psychosocial model that we introduced last time. It seems like a very simple concept, but it's really probably the most complicated thing going on in healthcare today, because what we're trying to do is we're trying to coordinate these different aspects of our population. So if I can get to see the primary care doctor and get my blood pressure checked, and maybe my physical health, my biology is okay, but perhaps I've suffered from a traumatic situation in the past. Maybe I have some underlying post-traumatic stress disorder that has never been diagnosed. This is actually quite common, and we're really just discovering it now in our elder population. In people that lived through World War II and the Korean War, there was no terminology for post-traumatic stress, as well as just other violent things that happen to people in their lives. Now we realize that there is a huge component of post-traumatic stress and pain. So people that have had a stressful situation in their past are probably carrying some psychological pain that is real. And then when they get into a physical situation where maybe they've had a surgery, maybe they have a migraine headache, or somehow they have a dose of a narcotic, it seems to alleviate some of that pain, but of course it really isn't getting at the root of that cause. And there is some good treatments for post-traumatic stress disorder, but it's not taking narcotics. So that's where we're getting into this component of the social aspect of this, and really what's expected and what's acceptable. 30 years ago, we had very few pain medicines in hospitals and nursing homes. Unless you had a major trauma, there was really long-term use of opioids were very rare. And in the rest of the world, they are still relatively rare for long-term use. Now, again, if you break your leg, you need narcotics. If you have surgery, you need narcotics for a short period of time. But this component that the social aspect is driving acceptance is an important component, because as the awareness swings, I think that this is going to be less acceptable, and I will feel the pressure between different, the president coming on TV and saying, we have a prescription drug epidemic, there's something we need to do about this. We have the American Cancer Society saying, yes, definitely. However, we want to make sure that patients with cancer have the medicine they need. And, so there's the social component that pushes and pulls, and I think nurses are more aware of this than anyone, but it's an important concept. So non-pharmaceutical interventions, we talked a little bit about this last time, but I want to go back into it again. Good evidence for their effectiveness, and more importantly, the value of their treatment. And that's because they have very few or no side effects, depending on which bullet point you're looking at. So the lower back pain, common condition for older folks, positioning can be a huge, can improve lower back pain incredibly. The difference between pillows and no pillows has been shown, and I'm sure you've seen before the difference. Massage, even touch, the psychological component of touch is an important piece of this. For some folks, a cold pack feels better. For others, heat is more comforting. The one caveat is for some folks that have diminished sensory, diabetics, we don't use heating pads in those populations because they can't sense that it's too hot. But for the most part, the massage, cold, heat positioning is great. And I would say 100% of our population, including myself, can benefit from these kinds of physical interventions. The psychological interventions, I suspect you're using them all the time, but I want you to think about having them part of every care plan. The idea that when we think about our pain all day long, and that's all that anyone asks us about, and as soon as the family member comes in, that's the first thing they ask about, and it drives the person, no matter who they are, to only think about their pain. And psychologists have done some great studies and looked at cognitive behavioral therapy as ways of saying, as we accept that pain is there, but we can be distracted, we can think about other things, we can look at pictures of family members, we can anticipate a weekend visit or someone that's coming to visit. We can use music. A lot of folks on the first call said that music was really one of their favorite non-pharmaceutical interventions, because once you know the kind of music that a resident likes, you can use it to really calm them down, help them get to some good memories. You have them, especially at bedtime or helping with sleep. So there is on the Geriatric Pain website, there's a great section that includes one-pagers on every single one of these interventions. And I encourage you, as you look at ways to improve the culture around pain in your facility, that you get those handouts, that you print them out, that you use them at staff training, that you make a way that everyone becomes aware and begins to say, this isn't just something extra if there's time. This is the main component of treating pain. Remember that the first level, always a non-pharmaceutical intervention. Controlled breathing. I don't know if you've ever tried it. I think we should just take a minute and try it ourselves. So I'm going to have you sit wherever you're sitting. Just take a moment, put both feet on the ground, and try and relax your shoulders. If you'd like, you can shut your eyes or you can leave your eyes open. That's fine. But I'd have you just have your eyelids feel relaxed. And, breathing just however you feel comfortable. You don't need to increase or decrease the breathing. Just take a couple of breaths. If your mind starts to think about how silly this is, that's okay. I understand that. Just let that go. That's fine. Just take a couple more, just regular breaths. Think about how your shoulders are relaxing. Think about how your sit bones, where you're seated, or how are you balanced? Are you comfortable there? Maybe if your palms are tight, maybe just open your hands. Just take another deep breath. Maybe think about something enjoyable that you'll be doing later today. And then I would just ask you to do a little self-assessment. When you started the webinar today, trying to call in, trying to figure out what was on your tune for 1 o'clock, how did you feel then, and how do you feel now? And I would guess that you feel better. And I think it's essential that people try this, that you have a family member try this if they dismiss it, because everyone dismisses this until they've tried it. And do go to the website again. There's a handout that's called Non-Drug Pain and Symptom Management, Controlled Breathing and Guided Imagery. And I am not an expert in this area. I basically, read through the handout. I've had some sessions on controlled breathing, but this is something that a nurse can do, that others can do to really help people begin to. It's not exactly distraction. It's a way to have the chemicals in your body slow down. Our brain is on fight or flight, and when you're in pain, your epinephrine, your norepinephrine, all of those chemicals are being released. And when you use this controlled breathing, there's good science that those chemicals diminish, that things are a little bit more relaxing, and that people, they gain some quality from it. So do not dismiss it. Try it with your residents, try it with your family members, and I think you will find that this is just one example of how these non-pharmaceutical interventions really are the key part of this treatment. Now, I hope everyone didn't go to sleep. You're still out there, right? So a little bit back to the evidence around these non-pharmaceutical interventions. These are some examples of payments that insurance companies will allow for lower back pain and other chronic illnesses. Again, 20 years ago, the culture was that insurance companies weren't necessarily covering a lot of this work, especially acupuncture. Now because we've looked at the evidence, because we've looked at a lot of the harms associated with the opioid medicines, even the Oregon Health Plan, which is our Medicaid plan in Oregon, where we're really trying to be cautious about how we use dollars, they are implementing for lower back pain, covering these conditions. And this will be for next year. They're still in the process of implementing this, but it just says how far we've come in understanding how these non-drug interventions have evidence behind them, that they have value, and that they're cost effective. So do not forget. And I realize that for a lot of your residents, they're not going to be doing cognitive behavioral therapy, but some of the other, even massage therapy, physical and occupational therapy is certainly something that can work for them. And I hear residents and they'll say, I don't want to do the physical therapy. I'm not going to get up and walk around anymore. I don't need that. And to help them understand that it helps with their pain, and it's just as much a part of a treatment of their pain as anything new. It's hard to introduce it, but once you've tried it, and for those of us, including myself, who've ever had to go through physical therapy, you know how valuable it is. So let's talk a little bit about a resident story. This is Mr. S. He was discharged from the hospital. He's admitted to your facility last week. He's taking numerous medicines, including the following. He's got PRN medicines, Tylenol, Vicodin, or hydrocodone, acetaminophen, risperidone, lorazepam, and zolpidem. I'm guessing that this looks very familiar. I used a similar slide with the last webinar, and we heard that especially when people come from the hospital, they're agitated, they might be confused, because I get confused when I go to the hospital. I'm sure everyone would. The hospital often starts them on an antipsychotic medicine, an anxiety medicine, a sleep medicine. So some things to consider. Once they get to your facility and they can be stabilized, the sooner that we get rid of those PRN medicines for agitation, the better. The more that we can implement a non-pharmaceutical intervention as baseline, getting an assessment for that care plan, and beginning to look at what are their needs in your setting. Not what were their needs when they were at the hospital, because that's where these orders came from, but what are their needs now that they're in a facility that's specifically designed to help them with their quality of life. So a word, and we talked a lot last time about, as you do psychotropic focus meetings with your pharmacist and your other nursing staff, you should always have pain and pain assessment as part of your worksheet when you're reviewing those medications and how people are responding. There should always be a component of how are we helping this person with agitation. Make sure that we're also relieving their pain. The other component that we see a lot when people come from the hospital is really high doses. So the zolpidem, for example, that is not a geriatric dose. That's a young adult dose. Lorazepam, also that's probably a 0.5 milligram would be fine for Mr. S. Most medicines have additional effects in the elderly, and they're more sensitive. So being aware of those doses as well. So I've been talking about pharmaceutical interventions here for a while, but we'll just run through them quickly. I think you know that, as I said at the beginning, I cannot teach you a course on pharmacology, and nor would you want me to. But thinking about pharmaceutical interventions in sort of 3 main categories helps me. So we always start with the non-opioid analgesics. Always, always, always. So we've already got our non-pharmaceutical intervention as baseline. That's in place. We probably have a non-opioid analgesic on board, and it's probably acetaminophen. The reason we don't use non-steroidals in the elderly population is they have many more side effects. GI bleeds, so gastrointestinal bleeds, used to be a pretty significant problem, much to the use of non-steroidal agents in older adults. So ibuprofen, naproxen, all of those we try and avoid as much as possible in elderly populations. Sometimes they're needed. People that have serious arthritis, or another a specialist has decided that for this particular patient, the risks and the benefits have been balanced. When there is a patient on a non-steroidal anti-inflammatory medicine, the guidelines recommend that you add a proton pump inhibitor, so that's like Prilosec or one of the medicines that can help with stomach acid to decrease the chance that they'd have a GI bleed. It doesn't take away their other problems associated with them, including kidney. It can be hard on the kidney, but if it's needed, there's some things that we can do. The opioid analgesics, I suspect that a lot of your residents now are on tramadol rather than on some of the traditional narcotics like oxycodone, morphine. So tramadol, the brand name was Ultram before it's been on the market many years now, so we have generics available. Tramadol is a medicine that was developed by a pharmaceutical company, and what they were hoping to find is all the good stuff that narcotics do. The opioids, relieve pain, help diminish muscle spasm, but we don't want all those side effects. We don't want addiction. We don't want tiredness. We don't want diminished breathing. We don't want itchiness. So they tried to develop a drug that would be the best of all worlds. And of course, they were not effective because there is no perfect medicine. But they tried. And with tramadol, I do admit that it is better. There is good evidence that it's a milder narcotic. It is an opioid medication, but it also has some serotonin along with it. So it has a lower intensity of the sedation, and some people find that it works well for their pain. The tapentadol is a brand new medicine that just came out, and I hope that you're not seeing a lot of that use. I think it's just another one of those, let's see if we can't come up with a newer, better drug that is more expensive. But this drug also is an opioid analgesic, but it has some norepinephrine component that's added to it. So potentially a little less drowsiness, although elderly folks did report drowsiness on the tapentadol. But you may see that occasionally. Again, it's not significantly better. It's milder, and it does have not only some of the side effects that we know about with narcotics, but both tramadol and tapentadol, because they have serotonin as one of the components and how they work, they have side effects that are not associated with the opioids, like a seizure. So people that have a seizure disorder should not be on these medicines. So again, you sort of learn about the opioid medicines, but then you have to set these two aside because they're opioid-like, but they have some other things going on. The third area that we talk quite a bit around with pharmaceutical interventions is the adjuvant treatments, and that's sort of everything else that we use. So we use antidepressants for neuropathic pain. We use lidocaine, topical lidocaine. Sometimes they'll use capsaicin, is the active component in chili peppers, but it can be useful for neuropathic pain. You'll sometimes see people after chemotherapy, they'll be on a combination of lorazepam, a narcotic like morphine, and then steroid like dexamethasone. And we consider those adjuvant therapy. So they have a different mechanism of action. They work at a different component of the pain, and sometimes they can be helpful. I'll go into a little bit more detail on the different adjuvants, but this is how I think of, when I sort of think of the world that is pharmaceutical interventions, kind of break them into these three categories. So those are the adjuvant treatments. I didn't mention the anticonvulsants, but we know now that Tegretol carbamazepine is useful for neuralgia and neuropathic pain. We have a lot of diabetics that have nerve pain, and narcotics really do not work for nerve pain. So the tricyclic antidepressants are sometimes used, the anticonvulsants. The cannabinoids are of more interest now that we have medical marijuana in Oregon, and I suspect you occasionally get questions or comments from family members about that. It is considered an adjuvant treatment. Corticosteroids, I mentioned. Muscle relaxants, especially for someone who has MS, baclofen can be a very useful muscle relaxant to keep that muscle from spasming. We have to be really careful with these adjuvant medicines because they also bring on a whole new host of side effects, especially in geriatric populations. So want to be cautious about that. I mentioned the antidepressants. They have the older antidepressants, the tricyclic antidepressants like amitriptyline and nortriptyline have a lot of anticholinergic side effects, so drowsiness, inability to urinate, can have some arrhythmias. It is a pretty serious problem. So every time you add on a medicine, you run the risk of having some additional side effects, and this is where a lot of the pain specialists come in. If it's a pretty severe situation where we're trying to adjust opioids, non-opioids, and adjuvants, I usually include a pain specialist. So this is a summary from the previous webinar, but for those that were on that first call, just again to realize the tides are really shifting. We are no longer going with that old model of more medicine, just escalate the dose of opioids. We know that there's limited data. There probably is some help for some people, but really important to balance the long-term potential side effects. We also know that around-the-clock regimens, which in our training we learned that was actually probably ideal because we didn't have to go to an as-needed regimen, that now there's a lot of pushback on that says, well, perhaps having a break during the day is better. And so if you have physicians that you're asking for orders for round-the-clock narcotic medicines and those physicians are pushing back, there's good reason why they are. Again, as a pharmacist, I spend a lot of time talking about balance. Pain is very complicated. We're sure that there are some benefits to treating chronic opioid treatment for non-cancer pain, but by far the risks in most cases outweigh the benefits, and especially once you get up to higher doses, you're really not getting benefits, you're only getting those side effects. So really individual, you got to weigh the situation, weigh the goals of that resident, and decide whether there's a benefit or if the risk outweighs the benefit to not include an opioid. So another story, Mrs. D has lived in the facility for 10 months. She takes numerous medications, hydrocodone acetaminophen, PRN pain, OxyContin 10 milligrams twice a day, and trazodone 50 milligrams at bedtime. She reports her pain almost constantly over the last 5 days. So this is one of those patients where we really want to try and focus what's going on, doing a complete assessment, trying to assess whether there's a non-pain related component, including all of our non-pharmaceutical interventions that we talked about, figuring out really for Mrs. D, is there something that soothes her? Trying a litany of things, because on some days distraction will be an effective mechanism, and maybe on other days when she's having more of that pain, she will need as needed hydrocodone acetaminophen. The OxyContin, taking it twice a day, always important when you see people that are on a narcotic when they come to the facility, that their needs, they may be on a dose that's too high, because as their body changes and as their condition changes, that may be a dose that was from 6 months ago or 3 months ago. So they may be on a higher dose than they need to be, or they may not be on enough medicine, and that's really where your role, it's complicated, but what your role is to consider, is this the right dose now? The other piece, which again we'll have to talk about quite a bit in January, is when she reports her pain, what is the timing of when we ask her? Has she had any pain medicine? So when we ask her right before her OxyContin is due, how is your pain? It's not good. What I'm thinking about right now is what I'm thinking about right now, which is my pain isn't good. I can't be thinking about what happened yesterday when I maybe had a good day. So being aware of when you're doing that assessment really can affect people's perception. And 5 days is a fairly long period of time to be able to recall back. So using techniques that help to recall back what worked yesterday when she was having a better day. Again, going to plug our geriatric pain website. They have it's a 2-page, just really 8.5 by 11, fairly small print, but excellent principles of pain management. So sort of that quick checklist that you might be looking for. Make sure you're remembering the non-pharmacological therapies, what to consider once those don't work, a good checklist for when to adjust doses. The second page of it includes some of the medications, potential side effects, dosing ranges, oral and IV injectable routes of administration. So, and does include some of the adjuvant side effects and considerations. So a lot of information packed into a couple of pages. It seems like something that you could have in the room where you're doing charting or where you keep meds, just as a quick reference for everyone. Some risk factors, you folks know this. I just want to remind you again when I mentioned earlier, as we get older, our body can't metabolize medicines as they did when we were younger, just because that's our bodies, that's how they work. They're wearing out slowly. And we're more sensitive to not getting sleep. We're more sensitive to upset stomach. Our kidneys and our livers aren't working as well. So all of this brings, in summary, we have to be really cautious with an elderly population when we're dosing. And then that last bullet point around the complex medication regimen, the more medicines that we have on board, the more likely that they're going to be overly sensitive to the side effects of that medicine. So if you check in the package insert of a drug like tramadol, it says do not use in combination with other medications that cause drowsiness, which we do that, but just to be aware how sensitive adding a second medicine is as far as decreasing respiratory rate, decreasing GI, getting constipation. So being really, really sensitive, not only for our elders, but based on how many medicines they're taking. So in general, the pharmacist will tell you, and I know you've heard that before, start low, go slow, meaning the doses. You don't want to be changing too many things at once. When you do change a dose, whether you go up or down on that dose, you want to make sure you're doing it slowly. No more than 25% increase or decrease in a dose per day. In some geriatric references, they say 10%. So we're not going to, our resident story that I said she was on 10 milligrams of OxyContin, we're not going to 20 milligrams of OxyContin twice a day. That would be 100% increase in the dose. You really, really tiny doses. And probably in that case, what we'd do is we'd be looking at as needed medicine and how often she was using that. When we do titrate medicines, of course, with fentanyl, the fentanyl patch, we definitely want to slow down if we're making any changes because it can take 3 to 6 days to reach a new steady state. So if you're increasing the dose of a fentanyl patch, you have to wait at least 3 days. And in the meantime, you can use alternatives. So doses. I promised I wouldn't do too much math, but I can't resist. So as we're looking at doses and doses of an opioid, I think it's important to be able to compare apples to apples. And the way that physicians do this is called there's different terminology, but equipotent doses is the term that's most commonly used. So how much in a hydrocodone acetaminophen tablet, how much is that in morphine milligrams? I can't compare hydrocodone to morphine because morphine is more potent than the hydrocodone. So how does that relate? Is it that conversion? So what I know that you have done before is if a person, let's say they're on morphine and they're taking morphine 15 milligrams twice a day, you add up 15 milligrams twice a day, this person is taking 30 milligrams of morphine. And then perhaps they're using morphine as needed for pain, and you check over, the last 7 days, look at if they've used that at all. Let's say they're using 2 milligrams of morphine once a day in addition to that. So that person's on 32 milligrams of morphine per day. And that's all that is. So you should be able to, and I know that you have calculated the total dose of all the narcotic that person's taking. But what's more difficult is, what if they're taking morphine 15 milligrams twice a day and they're taking hydrocodone? I can't compare apples to apples. So the clinical calculator is a way in which if you're switching, so let's say this example where I said this person's on 32 milligrams of morphine, maybe we decide, morphine's not working for this person, we want to switch to another medicine. What's the dose of that new medicine? And the way that works is we say, we convert it to the equipotent dose of that new medicine. And then we make assumptions that say, we're not sure, we're going to be really cautious. We assume that the math is an average dose conversion. So these dose calculators will decrease the dose by half. To say, just to get started, since we'll do a rough calculation, but then we decrease the dose by half. So it's just, again, a way to switch from one drug to the other. And I don't know how much nurses use that, but physicians use that quite a bit. So I wanted to show that. This is an AMA calculator. The other dose calculator that I find useful is in the situation where I said a person's on morphine and hydrocodone, or they're on fentanyl and hydrocodone. So my example where a person is taking, 25 micrograms per hour of a fentanyl patch, and then they also have 2 tablets of hydrocodone a day, 5 milligrams each, how much opioid is that? And what this dose calculator does is it converts everything back to morphine. So that, again, morphine is the apple in my analogy of we got to compare apples to apples. So basically what it does is it converts everything to morphine. And you're going to be seeing a lot of discussion about this in guidelines, because what the new guidelines have, especially for younger adults for chronic pain, is that the recommendation is going to be no more than 120 morphine milliequivalents per day, or no more. The CDC is coming out with their guidelines this month, and they're going to recommend no more than 90 milligrams of morphine equivalent per day. So if you go 90 morphine, I don't even know what that is. You go to this is the washington.gov website, and you type in, my patient takes, there's a fentanyl 25 microgram patch. So you type in 25, and then you learn that that's equivalent to 60 milligrams of morphine a day. And then you say, okay, but she's also takes 2 hydrocodone, 5 milligrams each. So that's 10 milligrams. How much morphine is that? And you can actually calculate it. And what this helps you do is to figure out, especially as new drugs come on the market, to even tramadol and the tapentadol are in there. So you can say, how much morphine is this compared to what she's been on? And it can help with looking at doses as you're changing doses. Just, again, a yardstick that we can all agree on converting back to a morphine equivalent. So do take a look at those. I think that's something that is not something that you need every day, but there's going to be a lot of discussion about this in the next couple of years around how many morphine milliequivalents per day is too much, and that's how you get to those numbers. I'm going to take a pause there. Any questions about that? It's kind of a little bit off topic, but I think it's important. Go ahead and just type in if you have any questions specific to that, and we'll have a few minutes at the end too if you want to talk about that. But the websites really are self-explanatory.
Yeah. Somebody said great tools, so
Oh,
I
good.
don't think it was really
Good.
off topic at all.
Good. Excellent. So talk a little bit about adverse reactions as we finish up today. As I mentioned, every medicine has side effects, even Tylenol. So for years and years, the acetaminophen is the generic. The brand name was Tylenol, and I try and use those two terms together so you can kind of remember the old days. And the brand company that made that medicine marketed it as the safest medicine in America, which unfortunately made people think there weren't any side effects. And the FDA, and through the monitoring of adverse drug events and reported adverse drug events, we've realized over the last few years that even a little bit more than 4 grams per day of acetaminophen is going to cause liver toxicity. And people have had liver failure and death. And the way that happened was maybe you're only taking 2 grams a day of acetaminophen, but you're also taking NyQuil, and you're taking some cough and cold product, and you're taking something else for sleep. And all of those things had some acetaminophen in it. So the main thing with Tylenol for most geriatric populations is no more than 3 grams a day is probably a safer place to go. And for most people, that is plenty. So 1,000 milligrams of Tylenol scheduled twice a day in the, with breakfast and dinner, or even 1,000 milligrams 3 times a day scheduled rather than as needed, is as effective as some nonsteroidals, especially if the person doesn't have rheumatoid arthritis. So a very effective medicine. The advertising, I think, makes people think, oh, well, it's not, I don't need that. It's too safe. It can't be good. I want the new stuff. When actually Tylenol is incredibly effective as long as you're staying, for geriatric populations, less than 3 grams a day. What the guidelines say is if you need to in a geriatric population, you could go up to 4, but no more than 4. But most of the experts that I talked to said they try to stick with 3, and that's for most populations plenty. And unlike the opioids, scheduling Tylenol is a great idea. We already talked about the nonsteroidals and their problems. A lot of side effects related to those nonsteroidals. So we really try to avoid those in our geriatric population as much as possible. The dual mechanism mixed opioids, the tramadol, the big serious thing is it lowers seizure threshold. And the tapentadol can, but the incidence isn't quite as bad. But with tramadol, if you have any history of a seizure disorder, you should not take tramadol at all. And if someone has a seizure, it should be reported through the FDA reportable events, because the incidence of this is actually much more common than what we thought when the studies were done. They were only done on a few thousand people, and now that a lot of people are taking the tramadol, we're realizing that there's a real potential for a seizure, especially if there's a history. Or sometimes there's other medicines that can decrease the seizure threshold, and those two together then can add to that. So tramadol, that's a big one. The other one is the serotonergic syndrome. That is, you're probably familiar with that, especially the nurses. That is serotonin, the medicines that affect serotonin. So most commonly the antidepressants, the SSRIs, like sertraline and fluoxetine. Those medications really, they can be mixed, and their potential for side effects can be additive. So when that side effect occurs, it can be within the normal dose. A serotonergic syndrome, basically what happens is the person looks like they may be either having a mild panic attack, increased heart rate, sweating, I don't feel good, something bad is happening. People in pharmacies have reported this, and pharmacists have caught it and been able to call 911. Some of it is fairly mild and it goes away by itself, but you can have arrhythmias, you can have a hyperthermia. A lot of people have ended up in the intensive care unit to get through a serotonergic syndrome. So from mild to life-threatening. Tramadol, especially in combination with other medicines, can really cause that. So I would suggest, as I know the nurses do, checking for drug-drug interactions for all the medicines and contacting your consultant pharmacist to have additional help with that if you have questions, where if there's two medicines that might have a potential for that serotonergic side effect, they would want to try and either decrease the dose or eliminate one that's not needed. The adjuvant treatments, I will leave some of this just because it could be a talk on its own. Side effects related to these medicines. Again, the references on the Geriatric website. There's good summary of how to manage side effects that I'll go over in a few minutes, but I will leave this to you to go into greater detail about the further adverse effects of all of these adjuvant treatments. The big ones for opioids, you know them well: constipation, even at very small doses, and nausea and vomiting. It really can be a problem for people. Anyone on a standing narcotic medicine should be on a bowel regimen. And with that, especially on very low doses, usually you can manage that constipation and the person will not have any discomfort, but the bowel movements need to be monitored very closely because you can get a bowel obstruction pretty quickly from the opioids. The other big one is the central nervous system. So decrease in cognitive, being less aware, everything to hallucinations. And of course, I've already mentioned the risk of falls. So depending on what that resident's needs are, if they are at risk of a fall, really rethinking the need and the use of an opioid, because it really is one of the worst of the drugs, just because it decreases our reflex. Respiratory, this is how people die of overdoses, and when, whether they're accidental or whether they're on a dose that was titrated too quickly, very, very serious adverse events associated with respiratory depression, especially with people that have sleep apnea. So as we learn more about sleep apnea, we know that people are at increased risk of this interrupted respiration when they sleep. So thinking of that as a real, a relative contraindication with sleep apnea and opioids. There's some effect on hepatic and renal. That's much more rare. And there's also some mounting evidence that these opioids decrease our immune system, which obviously is not great. We want to keep our immune system as strong as possible. I think I'll go ahead and skip through this. We've talked a little bit already about fentanyl patches, converting doses, the fact that people's pains needs change. If her weight change, those things can cause increased side effects related to these medicines. So being aware of that and really continually monitoring that respiration as well as some of those other side effects we talked about. So managing medication side effects, there's a great handout in my favorite website that you can take a look at. And what it does is a nice job of taking each individual side effect that I just referred to and saying, this is how we manage it. This is, on a point-by-point basis, drowsiness, how can I manage this? The CNS depression, talking everything from measuring respiration rates before giving any narcotic, using that as standing orders. A lot of good information about bowel regimens related to constipation, and as well as how to work on some of that nausea associated with whether positioning or different kinds of food, good ways to do a checklist on that. The other side effect that I didn't mention, itching or pruritus, that also can be a pretty big problem for folks. A non-sedating antihistamine can sometimes be used. But in general, that when you add a new medicine, you get new potential for side effects. So, but do take a look at that handout, because I think it aligns and pretty quickly as a checklist help you think about the side effects to be monitoring, but more importantly, what are the 5 things that can be done for each of those. So again, back to our original goal of quality of life. Really there's a multitude of medications that we could use. There is certainly a lot of non-pharmaceutical interventions that we want to make sure we have at baseline for all of our residents, and that the goal not be that we're pain-free, and that we're all aware that that is not the goal, and that we're all clearly aware as part of the culture of our setting in our nursing home that quality of life is really the goal, and having people safe and comfortable, and having them recognize that they can have a good quality of life even though there is some component of pain in their condition. So I appreciate everyone joining us again for this webinar. We have a few minutes for questions, and I think, let me see if we'll take some questions right now.
Operator, could you open the line for questions, please?
Certainly. Ladies and gentlemen, if you have any questions at this time, please press the number 1 key on your keypad. Again, if you have any questions at this time, please press the number 1 key on your phone.
Good chat questions.
I know you guys are shy. Well, that's okay. I think we got some good comments and some good prompts on chat throughout the talk, and Tyler was...
We have a couple of people typing. So.
Okay, good. Tyler was sort of prompting me to different areas and covering things. And so, again, I think it's fine to use the chat if you want to shoot me a question. And then again, I really encourage you to begin this journey of changing the culture at your facility and thinking about ways in which we start to focus on managing pain as part of quality of life that includes many, many other things and doesn't always include medications.
So Erica Nepper is asking, when we finish this next webinar, will we have some standard interventions for care plans and standard assessments that will be suggested to use? And I would say that yes, that is the plan and the hope that coming out of these webinars that we'll be able to sort of standardize this a little bit and give some tools to all of you so that we can hopefully improve this across the board.
And I think that's good feedback for our third webinar as far as assessment. What I have found is I've worked for many years in the area of changing behaviors, because that's really what we're doing when we were asking to try a new way of managing pain. It's difficult for me to come in and tell you how to do it, because what happens in your culture, in your setting, is you have to come together and say, this is how we are going to do it. And it probably looks a little bit different than what I had originally suggested, but there's 2 components. We can bring you tools and they can sit on the shelf and nothing will change, or you can work with us to create tools. And what we've done, at least in our previous quality improvement work, is really getting collaboratives together. So groups of nursing homes that check in once a week or once every other week and say, we're going to develop a tool together. We're going to use MDS as our pain assessment, but as we're doing assessments using MDS, we're going to put together a checklist, a screening tool, a way for us to be reminded about what we want to be thinking about as we're using those MDS assessments. And thinking about some of the components that we learned, and then probably incorporating some things that your staff wants to incorporate. And I would say that's how it's often worked in the past. A combination of, I can bring you some tools and you must then take the baton and begin to develop them for your facility. So thank you for that question.
Yeah, that was good. That's the only question that was in chat. So.
All right. Well, good. So part 3 of the webinar, January 2016. We don't have a date set, but we will let you know as soon as we know.
And it should be very soon that we know.
We're working on that date now. And then our contacts. I didn't put Leah's name on the Oregon contacts because she's just started this week. But the Oregon folks will be introduced to her very soon, and we're so glad to have her here. And appreciate everyone participating in the webinar today. We do want you to fill out your evaluation, which should pop up on the internet browser right after the webinar. It really means a lot to us that you fill those out. We took a lot of the comments and evaluations from the first webinar and tried to tweak some things to continue to address your needs. So appreciate your filling those out.
Thanks, everybody.
Thank you, and we'll talk to you in January.
Okay, ladies and gentlemen, that concludes your call. You may now disconnect your line.